Welcome, everybody. My name is Christopher Sorensen. I'm a board-certified family nurse practitioner with additional certifications in trauma, critical care, cardiac surgery, and cardiac medicine. I previously served as a senior staff nurse in the cardiothoracic intensive care unit, and I'm now completing my Doctor of Nursing practice, focusing on population health, disaster preparedness, and lipoprotein(a) associated cardiovascular risk. This presentation, Enhancing Provider Knowledge of Lipoprotein(a) and Atherosclerotic Cardiovascular Disease Prevention, is designed for healthcare providers, particularly those in primary care and cardiology. Our aim is to improve guideline adherence and increase population screening for lipoprotein(a), ultimately supporting earlier detection and better cardiovascular risk management. For patients or members of the public, I encourage you to review any information from this session with your cardiologist or primary care provider so it can be interpreted and applied to your personal health needs. By the end of this educational program, you should be able to explain the role of lipoproteins in atherosclerotic cardiovascular disease, differentiate LDL from lipoprotein(a), recognize the genetic and epidemiologic basis of lipoprotein(a), interpret lipoprotein(a) lab values, apply current screening guidelines, and identify emerging therapies targeting lipoprotein(a). Let's begin with a brief review of atherosclerotic cardiovascular disease pathophysiology. Let's begin today's presentation with a brief overview of atherosclerosis. Atherosclerosis develops from the gradual accumulation of cholesterol-rich lipoproteins within the arterial intima and along the aortic valve leaflets. This deposition triggers a local inflammatory response leading to luminal narrowing and vascular injury. These changes progressively weaken the vessel wall. When a plaque ruptures, the resulting fibrin clot could further luminal narrowing and it can release thrombotic material into the circulation. That clot could result in either a myocardial infarction, ischemic stroke, or other end-organ ischemia. When this entire process occurs within the coronary arteries, it becomes what we clinically recognize as atherosclerotic cardiovascular disease. While the exact cause of atherosclerosis remains unclear, endothelial injury is recognized as a key initiating event. When the endothelium is damaged, it becomes more permeable and pro-inflammatory, allowing lipoproteins to enter the arterial wall. This damage is primarily driven by smoking, high cholesterol, diabetes, and hypertension, collectively referred to as standard modifiable risk factors or SMRFs. These have long served as the foundation of atherosclerotic cardiovascular disease risk assessment and prevention. SMRFs compromise endothelial integrity, making the vessel wall more permeable to LDL cholesterol, which then accumulates in the intima. Effective management of these risk factors help preserve endothelial function and limit cholesterol deposition, thereby slowing the atherogenic process. However, without proper management, endothelial injury leads to the progressive thickening, narrowing, and ultimately restriction of the blood flow that makes up atherosclerosis. This slide compares low-density lipoprotein cholesterol and high-density lipoprotein cholesterol and atherogenesis. With respect to size, LDL particles about 18 to 25 nanometers are small enough to cross the endothelium but too large to easily diffuse back once bound. HDL particles at 8 to 12 nanometers are smaller, more spherical, and dynamic, able to move in and out of the arterial wall without being retained. With respect to function, LDL particles carrying ApoB100 deliver cholesterol to tissues. ApoB100 has positively charged regions that bind tightly to negatively charged glycosaminoglycans in the arterial wall, trapping LDL in the intima where it can be oxidized and glycated and trigger inflammation. HDL particles with ApoA1 lack this binding motif and instead act as cholesterol scavengers, removing excess cholesterol from the intima and transporting it to the liver. With respect to composition, LDL is lipid dominant, making it prone to depositing cholesterol and plaques. HDL is over 50% protein by mass, carrying enzymes and structural proteins that provide antioxidant, anti-inflammatory, and endothelial protective effects. Finally, there is a subset of LDL called lipoprotein(a) that is typically grouped with LDL cholesterol in conventional lipid testing due to its shared size and density. However, lipoprotein(a) is far more atherogenic and prothrombotic, meaning it drives substantially greater cardiovascular risk despite being measured as part of a total LDL cholesterol. Lp(a) is an LDL-like particle containing apolipoprotein B100 linked by a disulfide bond to a unique apolipoprotein A tail. The LDL-like portion has the same spherical size and shape, about 25 nanometers, and density as LDL, meaning Lp(a) is included in standard LDL-C measurements. This similarity allows Lp(a) to promote cholesterol deposition just like LDL, but the ApoA tail adds oxidized phospholipids and prothrombotic properties, making it even more atherogenic. The figure shows how Lp(a) mimics LDL structurally while carrying additional risk factors for cardiovascular disease. The ApoA appendage of lipoprotein(a) is the preferred carrier of oxidized phospholipids, OXPL, potent mediators of vascular injury. In endothelial cells, oxidized phospholipids upregulate adhesion molecules, increase inflammatory signaling, and reduce barrier integrity. In smooth muscle cells, they promote proliferation, arterial narrowing, and macrophage-like transformation, amplifying local inflammation. In valve interstitial cells, they accelerate mineralization and trigger osteogenic transition, driving calcified aortic valve disease. The result? Faster plaque progression, heightened thrombotic potential, and progressive valve pathology, making lipoprotein(a) both highly atherogenic and prothrombotic. Elevated Lp(a) is causally linked to ASCVD and valvular aortic stenosis, both major drivers of events such as myocardial infarction and ischemic stroke. Compared with normal levels, high Lp(a) increases risk nearly threefold for calcified aortic valve stenosis, over twofold for myocardial infarction, and 1.6-fold for ischemic stroke and peripheral artery disease, with elevated risk also for heart failure, cardiovascular mortality, and atrial fibrillation. In one ASCVD cohort, Lp(a) above 150 nanomoles per liter was associated with a 41% increase in major adverse cardiac events versus 35.6% in those with normal levels, and 8% higher risk for every 100 nanomole per liter increase. Using Mendelian randomization, researchers compared lipoprotein(a) to LDL particles, both of which contain ApoB. They found lipoprotein(a) is 6 times more atherogenic per particle than LDL. The graph shows that as ApoB rises due to lipoprotein(a), coronary heart disease risk increases far more steeply than with LDL alone. Even if less abundant, lipoprotein(a) has disproportionately high atherogenic impact. Elevated lipoprotein(a) carries similar ASCVD risk as being diabetic and a smoker combined. Each 50 mg per deciliter increase in lipoprotein(a) raises cardiovascular mortality risk by 16% with a hazard ratio of 1.16. The 3D graph on the left shows how lipoprotein(a) raises baseline event risk starting as low as 30 mg per deciliter. Most guidelines flag greater than 50 mg per deciliter as high risk, but patients between 30 to 50 may still need intervention based on their baseline risk. The right side shows lifetime event risk increases dramatically with higher lipoprotein(a), especially for those above 150 mg per deciliter and at the later end of their lifespan. This slide shows the global prevalence of elevated Lp(a), defined here as levels above 100 to 125 nanomoles per liter in 2022. Worldwide, about 1.5 billion people are affected, but the burden isn't evenly spread. South Asia has the largest absolute number, about 495 million people, or 25% of its population. Africa, on the other hand, has the highest prevalence rate, roughly 30%, affecting 418 million people. Europe and North America are each near 20%, Latin America and the Caribbean about 15%, the rest of Asia around 10%, and Oceania roughly 20%. In short, genetics and ancestry shape not only how many people are affected, but also how high their Lp(a) levels tend to be. Let's now explore the genetic basis of lipoprotein(a) and why it varies so much across individuals. Lipoprotein(a) levels are primarily genetic, about 70 to 90% heritable, and inherited in an autosomal codominant fashion, meaning most people express 2 lipoprotein(a) isoforms, one from each parent. The LPA gene drives this inheritance and encodes the unique apolipoprotein A tail. This tail contains 10 Kringle 4 subtypes, with Kringle 4 type 2 being especially variable. Individuals may have as few as 2 or over 40 Kringle 4-2 repeats, which determines the size and behavior of the lipoprotein(a) particle. Smaller isoforms with fewer Kringle 4-2 repeats are more atherogenic. They penetrate vessel walls more easily, promoting atherosclerosis, while larger isoforms carry less risk. While genetic testing is not usually required, a one-time Lp(a) blood test provides valuable insight into cardiovascular risk. Because of the inverse relationship between isoform size and concentration, we can often infer isoform size from a patient's Lp(a) levels. As shown in the diagram, risk-associated concentrations of Lp(a) typically occur when Kringle 4 repeats are 22 or fewer, with levels trending higher as isoform size decreases. By contrast, patients with 23 or more repeats generally have lower, non-risk-associated concentrations, which continue to decline with larger isoforms. On the right, the smaller and medium isoforms are illustrated. These forms are linked with markedly higher Lp(a) levels, often 4 to 5 times greater than larger isoforms. Lipoprotein(a) is reported in either mass, milligrams per deciliter, or molar, nanomoles per liter units. This causes confusion, but molar values are generally more accurate because they reflect the actual number of particles, not just weight. Mass units can be misleading since Kringle 4-2 repeats can vary in weight. For example, two patients may each have 30 milligrams per deciliter, but one may carry far more lipoprotein a particles, and thus more risk based on isoform size. As Kringle 4-2 repeats increase, particle count falls. For accurate cardiovascular risk assessment, molar units should be prioritized when available. Lipoprotein testing is now endorsed by all major global guidelines. The American College of Cardiology and American Heart Association in 2019 recommended testing in adults with a family history of premature atherosclerotic cardiovascular disease, identifying risk enhancement at levels greater than or equal to 125 nanomoles per liter or greater than or equal to 50 milligrams per deciliter. Then the Canadian Cardiovascular Society in 2021 recommended once-in-a-lifetime measurement during primary prevention assessments and separated risk thresholds into low, intermediate, and high, with more aggressive thresholds of greater than or equal to 100 nanomoles per liter for high-risk groups, but maintaining the equivocal mass-based 50 milligram per deciliter equivalent. European Atherosclerotic Society in 2022 recommended universal screening in adults, but also repeat testing in high-risk groups, while also maintaining similar high-risk thresholds or rule-in risk as the American College of Cardiology did in 2019. The National Lipid Association in 2024 recommended measurement in at least once in all adults greater than or equal to age 18 and mimicked risk thresholds in both nanomoles per liter and milligrams per deciliter as the European Atherosclerotic Society did in 2022. Despite guideline support, Lp(a) testing remains underused. In California, only 0.3% of adults had Lp(a) measured. Even among high-risk groups, testing rates stayed below 4%. Further, just 0.1% of providers ordered half of all Lp(a) tests, revealing a steep provider engagement gap. Reasons include low awareness, unfamiliarity with guidelines, and concerns about test cost or availability. These barriers are fixable with targetable education and better EMR prompts. Lipoprotein(a) is not just a passive biomarker, it is an actionable target for reducing cardiovascular risk. Several therapies can lower Lp(a). Apheresis can acutely reduce levels by 70 to 80% with sustained reductions of 25 to 40% through regular use. Niacin lowers Lp(a) by 30 to 40%, PCSK9 inhibitors by 20 to 30%, and fibrates by 13 to 39%. Statins, in contrast, may raise Lp(a) by 8 to 24%. The 2024 NLA guidelines emphasize that statins remain essential for LDL-C management and should not be discontinued because of Lp(a) elevations. In high-risk patients with elevated Lp(a) who need additional LDL-C lowering despite maximal tolerated statins, PCSK9 inhibitors or ezetimibe may be prioritized. Lipoprotein apheresis remains a reasonable option for patients with familiar hypercholesterolemia or ASCVD when Lp(a) is greater than or equal to 60 mg per deciliter and LDL-C is greater than or equal to 100 mg per deciliter on maximal therapy. Several promising therapies are emerging that specifically target Lp(a). Pelacarsen in Phase 3 has shown over an 80% reduction with results expected in 2025. Olpasiran and lepidosiran, both in Phase 2, have demonstrated reductions of nearly 95%, with large outcome trials underway. Together, these agents could represent a major shift, turning Lp(a) from a passive risk marker into a targetable, treatable biomarker, and potentially changing how we manage residual cardiovascular risk. All the more reason to ensure patients are screened today so that when more aggressive treatments come to market, we already know who will benefit most. At Maimonides Medical Center, our laboratory is fully equipped to process lipoprotein(a) testing. Importantly, results are reported in nanomoles per liter, the internationally preferred unit for assessing contributory cardiovascular risk. Step 1, begin in the cardiology outpatient order set. From here, navigate to the laboratory order set. Step 2, scroll down to the section labeled supplemental lab tests. Select this option to move forward. The system will then prompt you to associate the order with a health issue. For lipoprotein(a), you may choose from any of the screening-related health issues listed, for example, lipid screening, encounter for screening for lipid disorder, or screening lipid panel. Step 4, next in the order search field, type lipoprotein(a), exactly as shown, parentheses and lowercase a included. Select the test and the order will be added to your patient's chart. And that's it. The process is quick and straightforward. With this workflow, you can seamlessly integrate lipoprotein testing into your practice and help ensure patients are appropriately screened for this important cardiovascular risk factor. Lp(a) is a major driver of residual cardiovascular risk, even in patients with optimally controlled LDL. It remains invisible in most risk assessments unless we test for it. The NLA 2024 guidelines are clear. Every patient should have Lp(a) measured at least once. This simple test allows us to identify hidden risks today and prepare patients for tomorrow's targeted therapies. While no Lp(a) specific treatments are yet approved, clinicians should optimize LDL lowering therapies to reduce overall risk and consider referral to ongoing clinical trials. Screening is no longer optional. It is essential. And one last note, I want to thank you again for taking time out of your busy schedule. I'm grateful for the chance to share this work, and it is my hope that it will enhance your practice, one patient at a time.